to do with in that situation, stage 3 disease. Let's step back. Is there a specific criteria that you use to decide which patient will go for the lymph node biopsy, which patient do not need the sentinel lymph node biopsy?
Yeah, that's a great question. And this is something that has been answered through evaluation of many patients. The development of this procedure allowed us to determine the likelihood of a lymph node basin harboring more disease. So that was the justification of performing the sentinel node biopsy initially. In doing so, we found that there are certain patients that don't need a sentinel node biopsy because they have very early stage disease. So the likelihood of them having a sentinel lymph node that's positive is almost zero. And these would be very thin melanomas or non-invasive melanomas such as melanoma in situ. So I don't do a sentinel node biopsy unless I have disease of the original melanoma is a specific depth of invasion.
What's the depth? What depth are you using?
The criteria we use for determining sentinel node is based on a depth of greater than 0.8 millimeters in thickness or less than 0.8 millimeters in thickness, but there's presence of some poor prognostic factors such as ulceration of the melanoma. So any melanoma that is ulcerated or melanoma that is 0.8 millimeters or thicker in thickness, we would do a sentinel node biopsy.
And you mentioned, I think this is all great information because it's in line with the AJCC guideline, right? And but you talked about the depth and you talked about ulceration, but what about mitosis, the mitotic rate? Does that come into play?
It used to. We used to use that as a criterion, but we no longer use the number of mitoses as a criterion for determining melanoma, for determining whether a sentinel node biopsy is necessary. And that's probably because further evaluation of the data showed that the number of mitoses didn't matter. It was more correlated to, as far as a sentinel node being positive, more correlated towards the thickness of the melanoma and whether there was ulceration.
No, it's all a great point. And also, I think there's a mathematical percentage probability, right? And I think the probability of using number like 1 millimeters above is like you need to meet at least 10% of the chance, 10% of the time when you meet those thickness, and you will find positive lymph node. In other cases, less than 10% or 5 to 10%, and that becomes question mark, basically.
Right, exactly. And we usually think of it based on the data, it's probably around 5%.
Yeah.
When we do a sentinel node biopsy.
Yeah.
5% or greater.
And so we talked about the lower limit, the lower threshold that you will proceed with a sentinel lymph node biopsy. Is there any upper limit of the breast cell thickness that you will say, you know what, we should not do this? Let's say what happened if you have a melanoma with a breast cell thickness of 4 millimeters, right? No ulceration. Will you still proceed with sentinel lymph node biopsy, or you will say no?
Yeah, that's a great question because, and here we're dealing with advanced disease, and some people would argue, why bother doing a sentinel node biopsy when these patients are more at risk for distant metastases, spread of disease to other organs, and the likelihood of them having a positive sentinel node is going to be so high that we should just assume that they already do and just treat them like they are advanced patients that need systemic disease. But interestingly, these patients, I believe, should have a sentinel node biopsy, not for the reason of determining whether they have such aggressive disease that they need systemic therapy. Most of them should. However, it's more important to assess their lymph node basin, because if they have a negative sentinel lymph node, then we don't have to worry as much for disease progression within that lymph node basin. Of course, if they have disease within the sentinel lymph node, and then we can better monitor their lymph node basin to determine when they may have a recurrence in the future after systemic therapy. So the argument for doing the procedure is really a way of allowing us to determine the likelihood of progression of disease in certain areas of the body.
So you give some criteria about, when to do the sentinel lymph node biopsy. And next question is, are there any patient you will say, you know what, maybe we shouldn't do the sentinel lymph node biopsy procedure, even though they fit the criteria? Even though, let's say if a patient comes in with 1.3 millimeter breast cell thickness, right? Normally you will say, yes, we will proceed with the procedure. But are there any exception to the rule?
Definitely. I think it's important to realize that every patient is different. We individualize our treatment, we individualize our surgery based on the specific patient that we're dealing with. So, in other words, if we have a patient who is elderly, 90 years old, with a lot of comorbidities that can't tolerate general anesthesia, then we may say, okay, this patient will not benefit from a sentinel node biopsy because of the fact that the likelihood of this disease progressing within this patient's lifetime is fairly low. The other reason would be that this patient would not tolerate systemic therapy such as immunotherapy. And then in a case like that, doing a sentinel node biopsy wouldn't be advantageous. The knowledge of whether this patient has a positive sentinel node so that we can go on to treat the patient with systemic therapy is negligible.
So no, I think this is very important point. Like I think every time as a clinician we try to order a test, we should have downstream planned that whatever test, whatever information we're getting, we should be able to act on it. Right? If you're not going to plan to act on that information, perhaps we should think twice about not even ordering the test.
Exactly right.
And I think there's, sorry, I interrupted you. Please go on again.
If the findings don't change the management, then
yes,
it's not necessary.
Yeah, I totally agree. You and I have the same philosophy. And also, I think this is something else very interesting. Now, we sort of ran through the various criteria, everything else, but this is just give people a general sense about what their physicians may recommend. But at the end of the day, it is every patient is specific, every medical case, every situation is unique, right? So you really have to work with your surgeon to figure out, work with your surgeon or work with your physician to figure out what is the best path forward.
Exactly. Definitely.
Yeah.